Everyone. It's me, Malcolm Bell, hosting another in our session from Mayo Clinic of interviews with the experts. And today the topic is what cardiologists should know about aortic pathology. And with me today is Dr. Melanie Bois, who's an associate professor in laboratory medicine and pathology. She's an anatomic pathologist, has a particular interest in cardiovascular diseases, and in fact has a joint appointment in our Department of Cardiovascular Medicine. So, Melanie, really delighted to have you here. I don't remember the last time I had an interview with a pathologist.
Well, thank you so much, Dr. Bell. It's such a pleasure to be here.
Yeah, well, we're really pleased to have you with us today. So maybe I'll just start off from the get-go here. Is all aortic disease the same? And I think, in particular, I mean, we're thinking about big vessels here, and maybe we'll just start off. Is there a difference between what we see in the ascending aorta and the descending aorta, and how does that play into diagnostic considerations in our patients? And I should just also preface, I think what we're trying to do here is to give a better understanding of the pathology of our diseases and the patients that we're taking care of.
Absolutely. And I think that's a really insightful question. I think, when we talk about the aorta, we're talking about one of the most elegantly structured organs in the body. And I don't say that lightly. It's the way in which the aorta is structured from a microscopic and anatomic origin that makes it so incredibly useful and adaptive to the different types of strain and responsibilities that it has in the body. What do I mean by that? Well, the ascending aorta and the arch are actually derived from a different anatomic origin than that of the descending thoracic and the abdominal aorta. And we see these different embryologic origins manifesting differently depending on the type of disease that's present. For instance, the ascending aorta is relatively resistant to atherosclerotic disease that we may see a significant burden in the abdominal aorta. And part of that is secondary to those different hemodynamic parameters that the aorta is seeing in those locations, but some of it is also due to the way that it's structured and those embryologic origins that it comes back to. So yes, in asking that question, the ascending aorta is different from the descending thoracic, the abdominal aorta, and we see diseases differently and we see them manifesting differently based on those anatomic locations.
No, Melanie, I think you've already got the attention of our listeners here, because I think that, at least for me, I guess I've never really thought about that before. I recognize that, yes, I haven't really seen much in the way of atherosclerosis in the ascending aorta. We see it in the descending, particularly the abdominal aorta. And already you're telling us that there's already good reason for that, because these are derived from different embryonic processes here. So with that in mind, I mean, we know that the ascending aorta can dilate and have an aneurysm. You can have the descending thoracic aortic aneurysm and obviously abdominal. Sometimes they coexist, and other times they don't. So explain that. I mean, how does that happen?
Absolutely. So when we think about an aneurysm in the ascending aorta, for instance, much of this is going to be mediated by a few different conditions. The first major bifurcation would be inflammatory. So if you have a manifestation of a systemic vasculitis, like giant cell arteritis or aortitis, that can certainly weaken the ascending aorta. You can also get manifestations of underlying connective tissue diseases, Marfan's syndrome, Loeys-Dietz syndrome, which can lead to that aneurysmal dilatation. The dilatation that we see, though, in that location is what we call fusiform. It dilates in a relatively a uniform fashion, wherein the entire wall becomes damaged by this process in a 360-degree way. That's different from what you would see in an abdominal aortic aneurysm, for instance. Those tend to be saccular in morphology, meaning that there's a localized weakening, usually from atherosclerotic disease, that leads to an outpouching rather than a fusiform or 360-degree dilatation. So the type of aneurysm we're seeing often informs what that original disease was, as well as the location of it.
Well, Melanie, that's incredibly fascinating. But maybe we can just sort of delve down back into that sort of that microscopic area of what you're looking at. I mean, you're the pathologist. We often don't think about this there. And as you explain that, I'm also thinking of some other disease. I mean, you mentioned your Marfan's disease. I mean, and we know that in a lot of these patients, that's a sort of a defective protein, and so is there something that you can easily identify when you're looking at this microscopically? But that's just one part of the question.
Absolutely. You're talking to an area that I absolutely love, looking under the microscope and being able to translate that back. So it's a great question, and one I would be delighted to chat up further about. As a pathologist, I'm a very visual person, so you'll have to indulge me in a bit of an analogy here, rather than me, getting a whiteboard and drawing it out.
Oh, please go
Um,
ahead.
but what I think about when I think about the aorta is really focusing in on that aortic media. The media is the large portion of the aortic wall. And as a pathologist, we know that the aortic media is made up of these repeating lamellar units. So these lamellar units are kind of like individual sandwiches that are present within the wall. The outside of the sandwich then would be elastin tissue and collagen that's present. And that's bracketing these lamellar units. Inside, we have a smooth muscle cell, and we have this amorphous ground substance, this kind of mucoid type of material that's present. In the normal circumstance, these four elements work together to absorb the kick from ventricular systole, allow that ascending aorta to dilate through that elastin layer, maintain its structure through the collagen, and absorb that impact through that mucoid material, that kind of amorphous ground substance that acts as a shock absorber. The fourth component, that smooth muscle cell, is the living, breathing component that allows our aorta to adapt to any injury. And then we rely again on that elastic tissue to provide recoil and support diastolic dysfunction. When there is an abnormality in any of these areas, any of these four cell types or four types of tissue, then we start to get worried about specific underlying diseases. Let me give you an example. Marfan's disease, for instance, is a disease in the fibrillin gene. And we tend to see an upregulation in TGF beta secondary to this. How does that look underneath the microscope? Well, we tend to see breakdown of those sandwiches, those areas, those bracketing areas of the lamellar unit, where there's breakdown of elastin tissue and collagen, and an increase in that mucoid material. It leads to something that pathologists used to call cystic medial degeneration, where the large pools of mucoid material inside the aortic wall. And when we see that, we get very, very concerned about an underlying connective tissue disease. So we can tell you that in our pathology report. We can say that that change is present. And what we're trying to tell you is, I'm seeing this. This is abnormal for this patient's age, for what I know about this patient. And I'm very worried that not only the patient, but potentially their first degree family members may be affected by an underlying fibrillin mutation that could be followed up genetically.
So, I mean, you mentioned the pathology, and again, as a clinician taking care of these patients, if we if we're just managing these patients medically, we're not going to have any pathologic tissue for you, presumably, and unless I'm mistaken. If there's some endovascular repair, which is usually going to be restricted to the descending aorta and abdominal aorta, so any surgical pathology is going to come from ascending aortic repair, I assume, and any surgical intervention of the more distal part of the aorta. So, what are you looking for there when you see those pathologic specimens? And then how you use the example of you've got a connective tissue disorder that's or high suspicion. But what else can you tell us? Looking at that, and how would that impact the management of those patients?
It's a great question. You're absolutely right. In the traditional sense, the having a pathology report is worrisome for me giving you an autopsy report. But certainly there are instances in which the surgical specimen can come to us and inform the continuation of care in these patients. And exactly as you said, that tends to be in the ascending aorta that we see the most common surgical specimens. How we end up seeing that under the microscope in the setting of a connective tissue disease like Marfan's disease would be, again, an increase in that mucoid material, breakdown of those lamellar units or those individual bracketing sandwich areas, leading to this accumulation of material. We call that these days, this is going to be a rather technical term that was adapted in 2015 with the Society of Cardiovascular Pathology and Association for European Cardiovascular Pathology. It's called translamellar mucoid extracellular matrix accumulation, or translamellar MIMA. If you see that on your pathology report, that's an indication that there could be an underlying connective tissue disease at play. The other thing to be aware of or to look for in the pathology report would also be any type of inflammatory condition, because that's something that could indicate an underlying systemic vasculitis, like giant cell aortitis/arteritis, which is a systemic condition, like Takayasu, diseases like that that could certainly impact the patient and their management going forward.
And again, I'm just thinking about the different pathologies that may explain aortic aneurysm, dissection, rupture. And when you put this all together as a pathologist and understanding what's going on in that micro and even macro architecture of the vessels, does that make sense in terms of why Marfan's may progress at a certain rate versus one that may be just related to aging, hypertension, or bicuspid aortic valve? And so again, I'm just interested in the pathologist perspective, because you must have fun trying to put this all together, which explains what happens to the patient, or what is happening, or what could happen to the patient.
I love that question too. Yes, absolutely. We see more profound changes in the setting of syndromic patients or patients with underlying Marfan's Loeys disease than we do in the setting of longstanding chronic hypertension, in the setting of aortopathy associated with a congenitally bicuspid aortic valve. Those latter two categories tend to have relatively minor changes overall. We may see some smooth muscle cell death that's associated with it. We may see a slight increase in that mucoid material, but it's nowhere near what we see in the setting of patients with a heritable connective tissue disease. Those have much more significant changes that affect not only the mucoid material that's present, which is mediated by those increase in TGF beta pathways, but also the underlying structural disease that's present from the mutations in fibrillin or in the different categories of Loeys disease that you may see, including TGF beta receptors and that sort.
Okay. Well, Melanie, as we wrap this up, is there anything else that maybe that we've missed that you wanted to share with us? And if not, I'd really like to hear the take-home message from the pathologist. And again, this is someone we often don't think about, in the scheme of the management of these patients.
Absolutely. No, I appreciate the opportunity to chat with you about this today, for your questions and your insights. I would just say, if you are at all concerned, about your patient, or if they underwent an ascending aortic aneurysm repair, pick up the phone and call your pathologist, understand what they're seeing underneath the microscope. It may very well make an impact not only to your patient and recurrent disease or manifestation of disease in another portion of the aorta or another artery in general, but also to their immediate family members, if it's something that we can affect in terms of a heritable syndrome. So we do see a lot under the microscope, but in making sure that, as we do, Dr. Bell, I know you and I are on the phone a lot with our patients, being able to pick up the phone and have a good conversation about it can really mean a lot to your patient in the long run in terms of long-term management.
Yeah. Well, I think you summarized that nicely. I think the relationship between the clinician and the pathologist, you learn so much, from I mean, even just getting autopsies, just in general, or just really trying to understand what the pathology is that you're reporting and how that impacts the care of your patient. And so, Melanie, thank you so much. And then this is really a fascinating and very unique perspective, and I'm sure our listeners have really enjoyed listening to this. It just sparks some, maybe just an academic interest, or just to really understand what's going on in these patients. And then not just a CT scan or some tissue or some repair of an aorta. There is something more to it than that. So thanks so much for sharing that with us, and for spending the time with us.
Thank you, Dr. Bell.
Well, that's all we have time for today. I look forward to seeing you again in future episodes of our interviews with the experts.
At Mayo Clinic, relentless learning fuels world-class care. I'm Dr. Benjamin Hibbert, Chair of the Division of Critical Care Cardiology. If today's episode gave you a fresh insight, imagine what a full course can do for you and your patients. Head to cveducation.mayo.edu and explore our live and online programs, quick on-demand modules, and CME-accredited masterclasses created and taught by the very voices you trust here. Join thousands of clinicians who've already turned curiosity into expertise. Level up your practice now at cveducation.mayo.edu.